So I wanted to spend a little bit of time talking through my thought process on pain. When I'm working with somebody, because I think it really helps people who are not working with me to maybe try to find a doctor who thinks like this. Obviously, my way of thinking is not the only way of thinking, but if somebody is wanting to work with me, it usually means that what I'm doing resonates with them, and therefore they might want to try to find somebody who thinks along a similar lines as I do. And so I think for me, the biggest things that I look at is initially, is there a known injury? Okay, so if, for example, we have like two kind of paths we can go down. If there is no known cause of your pain, your injury, you just woke up one morning and your shoulder was hurting. You woke up one morning and your knee was hurting. And sometimes you have to be careful because some people will think that, oh yeah, you know, I did a heavy squat workout like 3 weeks before and then my knee started hurting. Those two things are probably not linked. Your brain is just looking to try and find a link, and so you're attaching it to that. So that's the one path. Is there a known injury, and is there not? If there's not, generally that's where I'm going to refer out. And the reason for that is because usually there is an underlying systemic contributor to that pain. There is a non-orthopedic cause to that pain. Now, there might be orthopedic manifestations of that pain. So, for example, somebody might have that, and then we might do an MRI or an ultrasound or an X-ray, or somebody else did that, and there are orthopedic findings. So, for example, there is patellar tendinopathy, or in someone who has, unexplained knee pain, or there is, a bursitis, hip bursitis. It's actually pretty rare, so I don't even want to use that. But let's say a glute med tendinopathy in someone who has hip pain, but they don't know where that hip pain came from. So sometimes we can see that the orthopedic result of that. That's still, I can help there, but at the end of the day, what really needs to happen is the underlying issues need to be evaluated and addressed. And so I'm usually referring out to either within my own practice, or if I need to, refer out to a great rheumatologist, integrative rheumatologist, somebody who deals with autoimmune conditions, because that's where we need to look at. We need to look at underlying inflammatory disorders that can cause pain in different areas of the body. So if somebody comes in and they've got shoulder pain, and that is because they played baseball and they injured their shoulder, or they landed and sprained their ankle, or if they were deadlifting and they hurt their back. Those are the things that are in my wheelhouse. That's when I really start to dig in on my path and start to work up these patients. So what does the workup look like? Well, an in-depth history. That is first and foremost. I always want to hear the story of how this pain happened. I want to go as far back as possible. And I also want to know all the injury and surgery history. So, for example, someone comes in, they've got low back pain. Well, did you ever injure your ankles? I want to know the first set of injuries that happened, because recreating that story, that timeline, is helpful in trying to understand the kinematics of how these things happened. Did somebody sprain their ankle a lot? And that resulted in some knee instability, and that resulted in excessive load on the SI joint, and now I've got an SI joint problem. Well, guess what? I can go in and I can address the SI joint. But if the knee instability that's actually coming from the ankle is never addressed, whether that's with me or whether that's with physical therapy or a different provider, then that low back, that SI joint, is still can continually be an issue because we're not addressing the deeper root cause, okay? So that history, going as far back as possible and walking through the entire thing. I want to know what it was like, what happened, what did it feel like then, how were pain levels then? Do you remember what made it better, what made it worse? And then in that, a key thing is what worked and what didn't work, okay? I want to know, did oral medications work? Things like Tylenol, ibuprofen, the standard run-of-the-mill stuff. Any muscle relaxers, were those used? Any opiates, were those used? Did you have any steroid injections? Any anesthetic injections? Did you have a radiofrequency ablation? Did you have surgery? Did you have physical? All of it. I want to know all of it. The reason is because that helps me in figuring out what may or may not be going on. Because if somebody had, let's say they've got low back pain and they have been through the the entire system, on the conventional side, and they've had an epidural, and let's say no change. They had facet medial branch blocks, and they had a positive response, but they did not want the radiofrequency ablation. So then let's say maybe they stop going to seeing the doctor, and then it comes back years later. They don't know that that's important, right? They go see another doctor. Well, then they have their sacroiliac joint injected, it didn't help. They were sent to physical therapy, that didn't help. And it's this cycle. Well, we already have that diagnosis there. If the medial branch block really, really helped with that patient's pain, they just chose to not do the RF, the radiofrequency ablation, then it's likely that it's the facet joints. And so that helps me in understanding, what might be in the wheelhouse for our diagnoses. So we do that. I get a little list going on in my head of what I think might be causing the pain. And then we do the physical exam. So depending on the area, the physical exam can last anywhere from 5 minutes to 30 minutes, especially if we're doing multiple different areas. The key with this physical exam is I am trying to recreate pain from my patient. I tell my patients this, I'm sorry. This exam, if I do it right, is gonna be uncomfortable. You might actually be flared for a few days. That's a good thing because it tells us we are on the right path, okay? I'm not just doing this to piss off people's joints. I'm not just doing this to make people hurt and then they leave and I don't do anything about it. The ultimate goal of this is when I put a needle in somebody, I want to be as sure as I can be that I am putting it in the right area. Therefore, my physical exam needs to be directed in such a way that it is going to recreate the patient's pain. There are different muscle tests, there are different orthopedic tests, there is the range of motion, both active and passive. There's palpation, using my hands to actually push in different areas. There's neurological testing. There are a whole bunch of different things that basically give us this like big kind of overview picture. And as things come in as positive or negative, or maybe incidental, or maybe they give us a completely different finding that we didn't expect, then I get to use my brain and I get to try and fit all these pieces together to try and say, okay, what single core thing can I make out of all of this? Which is why it's really hard when people reach out over social media and they're like, oh, I got back pain. What's my problem? What's going on? I don't know. It takes a whole lot of this puzzle piecing to try and figure out what is going on. And that's our physical exam. Then it's talking with the patient and really going through different options. I don't know a percentage of the time, but a percentage of the time I am really confident in my diagnosis. And I say to the patient, hey, look, this is really what I think is going on. Here are our options on what I can do to help with that. And then here are the support people around me that I think you should go see in conjunction to help with it, whether that's physical therapy, whether that is a rheumatologist, whether that's massage therapy, a good body worker, whatever it is. Or I am not so sure and I say, hey, this could be this, and I'm not exactly sure. So here are the next steps on us figuring out. Maybe that's a diagnostic injection where we just use lidocaine, we inject into the area to see what happens. Maybe it is doing some systemic work to see what clears up. Sometimes patients have an orthopedic thing going on, but they don't eat well, they don't sleep well, they're not exercising, and they've got all this gunk, inflammatory, just pain, and it's masking things. And so I say, hey, let's just spend 3 months. Let's do all these things that are going to help all these areas, and then come back and let's repeat this physical exam. Let's see how you are doing then, and maybe things will be a little bit clearer. Or we decide to treat a few things because I believe that all of them might be involved, and I'm not sure how we are going to figure that out without doing individualized injections. And so we say, hey, we got 2 things here that we're not sure of. Let's just treat both of them. Let's hope you get better, right? So sometimes that's an option. And then sometimes imaging. Sometimes we say, hey, we need to know if X, Y, or Z is going on, and an MRI or a CT or an X-ray or an ultrasound is going to be best at doing that. And then we proceed with the intervention, which is, in my world, is the procedures. So then from that standpoint, there's still even further diagnostic capabilities there, because when a patient comes back in 6 weeks, 3 months, 6 months, whatever it is, and we talk with them, we find out how they did. That's really where the diagnosis comes from, in my opinion. The diagnosis is just a theory before we actually do any interventions. The diagnosis is confirmed when we've actually moved the needle on somebody's pain. So as an example, we believe that pain is coming from the sacroiliac joint, so our diagnosis is sacroiliitis. That's a theory. Until I put a needle in it and I put something inside that joint, I treat the supporting ligaments, I treat the, whoa, I almost got taken out there. I treat the things that are the pain generators from the sacroiliac joint until we actually see if that person gets better from that. It's a hypothesis, it's a theory, and theories can be good, but they're not set in stone until we actually do the therapy. So when they come back in 3 to 6 months, whatever it is, we can say to them, or they can say to us, yes, I actually saw improvement in my pain, so therefore we know that our diagnosis was correct. Or a small percent of the time, in our clinic it's about 5%, patient comes back and says, I'm no different. And I go, crap, okay, what did I miss? Let's step back, let's reevaluate, let's look at this from a different angle that we weren't looking at it before. So that way we can try and figure this out to help people. And again, even still, sometimes we end up getting the diagnosis, other times I don't. There is a failure to this because there's an art to this, and that's just the way it is sometimes. So this went longer than I expected, but I hope that this really brings a lot of value to people who are suffering in chronic pain. And I really hope that this helps people to be able to figure out what's going on with your pain. Because if you don't understand your pain, you're gonna have a much harder time actually addressing that pain. And so spend the time, either it's with yourself or with another doctor, to understand your pain, to try and figure out, why is this happening? What is going on? What am I experiencing? So that way you can take the steps to improve and or resolve it. All right, see you later.